are going to get started. Welcome. Thank you for coming to the talk. My name is Daniela. I'll get into who I am in a second, but I'll be presenting today on culturally sensitive approaches to working with families. Here's our agenda. So we'll kind of go through what's attachment, how people working in direct care can enhance that relationship, and then more specific cultural considerations. So that's me. I'm a bilingual trauma therapist. I am EMDR trained. That's eye movement desensitization and reprocessing therapy. I work at Quest Counseling and Consultation Center in Madison, Wisconsin. My bachelor's is in psych and my master's is in clinical psych. And I just decided to take that path because I wasn't sure what I was going to do after, if I wanted to go into counseling or not, but here I am. So, some acknowledgements. We acknowledge that we are on native land of the Ho-Chunk and Menominee Nations. We also acknowledge that this presentation is based on my own individual experiences working with families from a variety of different cultures, so it can't be generalized to everyone, but hopefully you have some takeaways from the families I have worked with. So, I like to start with this quote. When children have explosive and persistent challenging behaviors, it's a signal for adults to pay attention. It's not a purposeful manipulation on the part of the child to get attention. And that is, if your readers, Beyond Behaviors is a really good book. If you're working with families where the child may have really challenging behaviors, a lot of families I've worked with, sometimes they have kiddos with reactive attachment disorder or ODD. So what is attachment? It's the psychological connection between humans. It starts very, very early on with the infant and their caregiver. There's 4 types. There's different names for them, but I'll get into the types in a bit. But there's secure attachment, which is created in a validating and nurturing environment. And then we have non-secure, and then that's split into 3 categories. And that's just when something has disrupted the attachment that results in usually anxiety or avoidance. So, attachment styles can follow people into adulthood, but it can also change over time. So just because you have one attachment style when you're a kid doesn't mean you're going to have that attachment style as an adult, depending on the relationship that you have in that time. So I'm going to play a video here. Some of you, if you've taken an intro to psych course, you probably saw this still face experiment. But it'll just give you an idea of how important attunement is.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
So this is an example of a child who's pretty securely attached. Like you can see, yes, she gets distressed when her mom isn't responding, but then once she reattunes, she's okay. And that's usually what you see with kids, is that they still get distressed like any child would. However, they are able to be soothed pretty easily. All right, so these are the 4 attachment styles in children. So we already kind of went over secure. Their caregiver is a source of comfort, and they're easily soothed. And then we get into the non-secure attachment styles. So we have the avoidant type, and that's when a child maybe seems like they don't care a whole lot, may not show a whole lot of emotions, might say things like, "I don't care, do what you want." And they don't respond to a caregiver being absent. So if some of you are familiar with the, forget what it's called, but the stranger scenario, where there's a child in a room, a stranger enters and plays with them, then you have the parent also enter and play with them. With kids with avoidant attachment, they don't respond any differently to the parent or the stranger. And then we have the ambivalent type, which is managing anxiety by, quote unquote, control and demands. Again, with kids, it's really important to try to view it as they're not being manipulative, right? Every behavior is a reason. There's a need that needs to be met. So it's not that they're necessarily trying to control or demand things. It's just that's what they've learned. So with this attachment style, you see that with kids that have separation anxiety, they're difficult to soothe. You'll see tantrums. So if you tell them, no, you can't have that, you might see more of a explosion. And you'll also see that if the parent doesn't pay attention to them, they might be overly jealous of their parent interacting with other children. So that's more of what some people would call, again, quote unquote, needy, which I don't like the use of that word, because again, they're not needy, they just have needs that aren't being met. And then you have the disorganized type. This one is most common in kids that have gone through some sort of abuse or neglect. This one is where they want to be close to their caregiver, but they're also scared of their caregiver. they often seem dazed and confused, so you might find a kiddo that maybe you start to see because they have difficulty concentrating. So they might sit in class, kind of, look around, not really pay attention. They might not be seemingly paying attention to an adult when you're talking to them. It's important to know a child's history before kind of following through with the diagnoses. Because a lot of times you'll see symptoms of ADHD and other mood disorders as well that are based in the trauma. So the approach that I follow is treat the trauma first, and just working together with the team, making sure the school's involved as well, getting to see what the teachers are seeing in the classroom. But you also see that these kiddos can be both avoidant and also aggressive. And then we look at the attachment styles. In adults, secure adults, relationships are mostly happy, comfortable being close and expressing emotions. They can be apart from their loved ones and still know, like, we're going to get back together, no one's going to abandon me. Fine. And then we go into dismissive, and that's what is kind of the counterpart, I guess, to the avoidant child attachment style. So a lot of times adults might seem cold or distant in relationships. A lot of they don't care about me, they don't respond to me, like, why aren't you paying attention to me? These folks, it's not that they don't care. Actually, in studies, they found that the cortisol levels, the stress hormone, is elevated even when someone is cold or distant in their relationship. We have the preoccupied types. You also hear it called anxious attachment. These people, again, are oftentimes labeled as needy, afraid of abandonment, usually need a lot of validation. Sometimes you'll hear, like, you're not going to leave me, right? Or you still love me, right? After a argument, say, with a significant other. Seemingly can't let things go, so, sometimes they might just hold some grudges, and it's because it hurts. And then disorganized, you might see a lot of dissociative behavior, disorganized speech. Sometimes you'll see long pauses or getting their words mixed up when they're talking about trauma. So something to watch out for, and just make sure that you're able to kind of guide them through the dissociation before continuing any session. So, discipline and caregiver behavior. So, timeouts, I'm sure, I had them. I'm sure you've all maybe used them in your own families. So, the idea of timeouts isn't to punish a child, it's to calm, right? So, it's an opportunity for both the caregiver and the child to take a break, regulate, and then come back together. So when you're talking to the caregivers, it's important to tell them, like, okay, yeah, you can take a break, separate, but you have to come back together every time and try to repair what happened. So there's that idea of good enough parenting. It means that not everything has to be a learning moment. You're also going to miss things sometimes. There's going to be a behavior. Caregivers also have their own stuff going on, so they might just be tired or say something that they don't mean. But if the majority of the time you're doing what you can, it's just repair as much as you can. So discipline versus punishment, I think, is important. Discipline is a way to teach. You're teaching a child how to behave so that long-term it's a behavior that they don't repeat that often. Whereas punishment, it comes more with shame. Punishment is more like having a child pay. And that is not good for attachment. That's where you get some fear responses from the children. So with discipline, it's mostly establishing a boundary. So for example, in a session, you might say, oh, help me pick up these toys, and they refuse, and it's like, okay, we're not going to be able to take them next time. Next session comes, reminding them, hey, remember last time you didn't help pick up the toys, so we're not going to be able to use that today. Can we pick something else to use today? You'll see that avoidant children, the reason that they might avoid showing emotions is because they've now learned my caregiver isn't going to respond to these big emotions. They're not going to respond if I'm needy. Disorganized caregivers can transmit their own stuff onto children, which is where co-regulation comes in and is important. You want to make sure that as a caregiver, you are regulated, and therefore the child will be regulated. I think at some point I mentioned mirror neurons. So, if you yawn, you see someone yawn, you'll yawn. So when you're a child, you smile at a baby, they smile back. So kids are picking up on everything that their caregiver does. They've been watching them for as long as they've been alive. So they can easily detect when a caregiver is stressed or a caregiver is sad. So sometimes with disorganized caregivers, they might have more of the panic look on their face, and then usually the kids tend to pick up on that and then also start to get dysregulated. And then preoccupied caregivers can be inconsistent with attention. So preoccupied, again, are the more anxious type of caregivers. Usually they're resolving their own internal state rather than attuning. So you see this often when maybe there's one caregiver who is more distant or less present. So the caregiver is now going through their own form of anxious attachment. So they might turn to the child. Usually it's not consciously, but they'll take the affection from the child to soothe their own internal state, rather than it being a nice moment between them. And again, most of the time, none of these things are conscious. It's just things happen to us, and then we learn about relationships. So then, how do we enhance the caregiver-child relationship within sessions? Sessions or visits. I see that there were a lot of different people. Some of you work in schools, some of you do in-home and things, so I'll just say interactions. Direct care sessions. So if you are working directly with a caregiver and a child, it's important to have the caregivers present. I say always, but that's ideal. But if that's not possible, doing the check-in with the caregiver and the child, doing a small attachment-based activity, and I'll show you some examples in a bit. And then, yes, you can do one-on-one with the child if you want, and then check out with the caregiver at the end. But as much as possible, we want to have the caregiver involved in those sessions as well. Again, I'll get into attachment-focused activities in the next slide. Caregiver education through modeling and psycho-ed. One of the first things I tell caregivers is to try to change thinking of it as attention-seeking behavior and more towards attachment-seeking behavior. Again, I'll keep saying it, a behavior is communication that a need isn't being met. And that's actually what I said up there. Psycho-ed is really important. So again, if you know about these attachment styles or you look into them a little bit after today, you can help caregivers as well see what attachment style they have and how they might think that might affect their child. And it just helps build a relationship a little better when there's a understanding. As far as modeling, you all, as the person perhaps working with the parent, or if you're a parent, maybe you're observing your team during these sessions, it's important to model play with kids. So what does that look like? Adults, we all know how to play games by the rules. So it can be a little activating maybe when a child's like, no, I'm going to skip to the end of Candyland and play backwards. You kind of have to just go with the flow. If it's okay if they change the rules to games, and kind of teaching that, like the child gets to lead the play, because we want it to be fun. We want it to be something that they look forward to. And then the younger, of course, let the child lead. As they get older, you can start slowly implementing this idea of rules. Setting boundaries, again, the example I used earlier of putting away the toys, just showing how to have those healthy boundaries in place that are more discipline-based if there's a behavior you don't want repeated. And then co-regulation, so responding to the child. Sometimes if you're talking to a caregiver, the child might try to join in the conversation or say, hey, look, Mom. You still want to acknowledge the child is doing something. So being like, oh yeah, no, I see you. Actually, why don't you go pick a game for us to do while I finish talking to Mom or Dad? And then following through with consequences, again, this is discipline-based. So if you say something like, we're not going to play with this next time because we weren't able to follow directions, making sure that that actually happens. That's a boundary that you're setting for the sessions. So making sure that if you say there is a consequence for a behavior that maybe was dangerous, you want to make sure that you follow through with that next time. So attachment-focused activities, things you can do. These can be in sessions. This can be if you're a parent. Anything with co-regulation. So again, mirror neurons, anything where you're responding to each other, watching each other. Self-regulation, so also just making sure that you're in a calm space. And that actually goes for you all as well. So if you're having a day where you're not very, let's say you're tired, or maybe there's stuff going on, maybe it's time to start with a nice mindfulness activity, and then you get to do it too. And again, following the child's lead. So some activities or ideas for activities. I like to use Jenga or Kerplunk. I don't know if you're familiar with that one. There's a little bin with marbles, and you pull out the sticks, and then they fall. So with this one, you're trying to build a tolerance for hearing the word no, because that can be really activating for kids. So you start with something small like in play. So you have the caregiver and the child together. All right, like we're going to play this game. However, your mom or dad is going to let you know if you can take that piece or not. So you'll have to point to the piece and ask, can I move this one? And if they say yes, you're good to go. If they say no, you have to pick a different one. So slowly, that child starts to hear the word no in a setting that's fun. And also just, if, let's say, they do it anyway, again, that's a good chance to establish a boundary of, oh no, we're going to have to start over now. And sometimes the kids really like it when you switch it around, so then you have the caregiver ask, can I take this piece? And they get to say yes or no. Red light, yellow light, green light, purple light. So you all know red light, green light. So it can be a physical activity, so you can have kids either run, speed walk, jump, normal rules, and then purple light is just a silly way of saying as fast as you can. You can also do this with drawing, so if there's any mobility issues or just you don't have a whole lot of room for physical activity, I like to do scribbling. So if you're scribbling, you stop, you go slow, You go really, really fast. Then we have collaborative board games or card games, so nothing where you're playing to win, because that's really tough on kids too. So something where they have to work together, because then you're building that attachment, that co-regulation, you're still building that relationship through play. And then, as I mentioned with co-regulation earlier, Patty Cake and Simon Says are really good ways to have the child and the caregiver attuning by looking at each other. And then pretend play. I'll get into cultural pieces with this in a bit, but playing whatever. If you have a doctor set or a toolkit or whatever, just having them play together. Let me see, how much time do I have left? I'm going to skip the video. So understanding the child brain, you want to make sure that you understand what is age appropriate. So a lot of times I'll hear something like, my 3-year-old is just trying to make me upset. Well, they can't do that yet. They're not doing anything to be manipulative, right? Like they're learning cause and effect, but they're not doing it maliciously. So kind of updating your own knowledge, but then also teaching that to the caregiver. Like what is age appropriate? Upstairs, downstairs brain, in a nutshell, I like to think of the brain as having the upstairs brain is your frontal lobe, all those complex brain things, and then you have your downstairs brain. That's more of your automatic responses, more of the emotional stuff. And that's based on, I was going to show Dan Siegel, but the Whole Brain Child talks all about that, and it actually has a number of things that parents can do with their kids to help them. So that's a really great book to have caregivers read. So the idea is a lot of kiddos with non-secure attachment get locked in the downstairs brain. It's automatic, it's fight or flight response. Right? They're not throwing things thinking I'm going to hurt my brother or sister. They're thinking the back of the brain said, oh, there's a danger, there's a threat, I need to defend myself. And with the fight response, you're going to throw something. With the flight response, you might try to run away, run out the door, run into the street. And then freeze is just, you just see children freeze up. Bilateral stimulation, that's from EMDR. I will show you what that is in the next slide. And then we've already talked about mirror neurons. So again, these two books are really great. They can both be used with parents. I would recommend Whole Brain Child as the first one to recommend. So bilateral stimulation, it's used in EMDR. We use tapping, we use the eye movements. So what it is exactly what it sounds like. We're stimulating both sides of the brain. That gets at, well, you've heard, oh, right brain is more emotional and artistic, and the left side of the brain is more logical and rational. And, it's a very general way to put it, but there's some truth to that. So what we're trying to do is make sure that both sides of the brain are being activated at the same time. So even by touch, so tapping, the feeling of my hand touching my arm or that movement of my hand is going to stimulate both sides of the brain because the left side of the brain controls the right side of the body and vice versa. So this helps calm the nervous system, right? Because then if you're in the emotional place, you're super distressed, you do some tapping, you're then able to think logically through it. You can't think your way out of a tantrum. So when you try to come at a child with logic, that doesn't work very well because they're not listening, right? They're stuck in that downstairs brain. So you can use bilateral stimulation. You can have the caregiver tap on the child. You can have the child pace around, right? Your legs are moving. And just, it helps meet sensory needs. So whether it's tapping, eye movements, sounds, any of those work. And you can involve the body as well, like I said, walking, running, tapping, scribbling across the visual field, drumming. I like to keep these light up drumsticks in my office, kids love them. And then jumping, alternating feet, either with a jump rope or a trampoline, are all forms of bilateral stimulation. And again, the function of that is to calm the nervous system so that then you can actually talk to the child and make sure that they are absorbing what you're saying. So here we get into the cultural considerations. Again, this is from my own experience, my own research. So you might see some things differently. Every family, every individual is different. But these are some common ones I've seen. So we'll be talking about adult play. What does play mean to the caregiver? Trauma experiences, both the child and the caregiver. Expectations of the relationship, setting boundaries, collectivistic versus individualistic cultures, and then the caregiver's attachment style. So adult play. Immigrant caregivers or caregivers that grew up in poverty, oftentimes you'll see that they had to do adult things very early on. So they didn't really get the opportunity to play as much as someone who, say, had more access to toys or just more opportunities. So an example for me, my parents are both the oldest of 10. So my dad got to second grade and then had to start working. So he really didn't get a chance to play. And I noticed that. Luckily, well, actually not luckily, I was a very ambivalent, anxious child, so I demanded a lot of attention. But we would play board games together. And that was a really easy way to kind of get him to start to understand what it was, flexibility. He was a really quick learner, so it worked out. And my mom was 15 when my grandmother passed away, and she had to raise 4 of her siblings who were infants at the time. So she really didn't get a chance to play much. And of course, within the Latina culture, she was the oldest girl, oldest daughter. So she was expected to take on a lot of the adult things, looking after the siblings, cooking for the family, cleaning everything. So some ways to kind of help with that. Reading a book or storytelling with the child is a very easy way. Having a selection of books in a variety of different difficulty levels is really great, so that the caregiver can, together with the child, pick out a book, having them either sit next to each other, or if the child's okay sitting on the caregiver's lap, having them read together. They're getting that connection time. Storytelling is really cool for, so that the caregiver can share their stories. We also want to be mindful of what stories they're sharing, making sure they're appropriate for a child to hear. And yes, board games and card games with specific rules are a good way to introduce caregivers who maybe aren't super comfortable with play. So this is where I get into pretend play is not for everyone. Some caregivers are really uncomfortable with the silliness that comes with the pretend play. Imagination can be different, creativity. We know that in people with severe depression, we get especially concerned when creativity goes away. Because there's a quote of where there's creativity, there's hope, and that is true. So kind of get to know the family first before introducing pretend play. So good ways to start: card games, board games, loteria, which is one of my favorite games growing up. Granted, we use quarters. I do not recommend gambling with the quarters. But, you know, you can put some treats in there or something if you want. But loteria is really nice. Again, depending on literacy levels too. It has the images, it has the words. It's basically a Mexican bingo. So that's a really great one. And a lot of my Mexican clients, when that gets brought out, they're super excited because they know what it is, they know how to play it. Uno, pretty easy to teach. I forget what the recommended age level is, but follow the instructions on the box. And then Guess Who or Pictionary are also great ways to start to be silly without it feeling like it's pretending. So of course, you know, if you're drawing something, maybe the caregiver isn't the greatest artist, so then the kiddo laughs and they laugh, and you know, it's a good opportunity for them to get creative. And then yes, Guess Who is a fun one too. Also, one where reading isn't necessary. So taking into consideration caregiver trauma, intergenerational trauma, we see that coming up more and more. There's a lot more research about it. If you're familiar with Body Keeps the Score and really any book that hints at any of this, trauma affects everything. It affects our genetics, it affects our physical health, and those things tend to get passed on just with biology. So there's some things that have happened that do get passed on generation to generation. Having someone grow up in an abusive, violent household, that might be the norm, to discipline by spanking or hitting of some sort. You know, as a Latina, we joke about the chancla, you know, like the shoe. Joke about it now because I'm fine, but when you think about it, a child isn't going to understand that what it's meant for. They're just focused on what happened, right? So my parent hurt me, my parent hit me. So that can get passed on in forms of discipline. So I always like to do a genogram, if you have time for one, where you just go through all of the, kind of like a family tree, but really detailed to observe not just medical and psychological or psychiatric conditions, but also what did discipline look like? What did affection look like? And then you know where to focus your energy. Systemic trauma. Racism, just generally. And you can see that also in systems like medicine. So sometimes there's a mistrust in the medical system by BIPOC and LGBTQIA+ individuals. And that's just years and years of trauma that have happened. So BIPOC individuals are less likely to receive pain management. We see, especially with Black folks, they can go into an ER with the exact same pain level as a white individual and be a lot less likely to be given temporary opioids to treat the pain, even though their pain is at that level. Because of these implicit biases. There was a study that said 40% of first and second year medical students agree with the Black people have thicker skin than white people, right? Like they can tolerate more pain, which is not true. There's also this fact that is thrown around that is not a fact, as we know now, but has been passed on through medicine forever, that Black individuals' nerve endings aren't as sensitive as those of white folks. Also not true. So you can see why they might not want to talk to their doctor about mental health on top of the physical health that they're already having issues with. We see the higher mortality rate in Black women from pregnancy complications. They're 4 times more likely to die than a white mom. Again, very similar issues there. A black woman might go in and say, hey, there's something wrong. I know there's something wrong with this pregnancy. And the doctor might be like, nah, you're fine. Like, it's nothing, without checking. And again, these are all implicit biases that exist. You see it more often with white clinicians, but it's also with non-black folks who might also be indigenous or people of color. There's also a history of non-consensual medical research. So the syphilis study that happened, experimenting on black men with syphilis. It was a study where they basically allowed black men with syphilis to get worse and worse without treatment, even though the treatment at that time had been found to heal or get rid of the syphilis by just taking an antibiotic. And they were not given antibiotics in the name of medicine. And then birth control experiments on Puerto Rican women. Puerto Rican women were basically just given a birth control pill without telling them what it was. So in both of these cases, there was no informed consent. So there's just been a lot of BIPOC individuals and LGBTQIA individuals who have not been treated well by the medical system. So you can see how they might be anxious to come to mental health services or to allow someone into their home. There's also a lack of representation and language barriers among mental health providers. So I don't know if any of you have worked with interpreters, having the awkward triangle, right? You're maybe trying to communicate something. A lot of times the interpreter is not translating exactly what you're saying because they're adding their own spin to it. Again, not consciously usually. A lot of times is they're trying to change it to be more understandable to the client. I experienced this because I worked as a rape crisis center on-call advocate for a while, but because I was not an interpreter, we still had an interpreter in the room when I would work with the Spanish speakers. And I would say something, and they would interpret it completely wrong, and I knew that. So you'll see that a lot. And then just representation. You don't see many BIPOC clinicians out there. And a lot of times people just need someone to trust who looks like them, sounds like them. In my experience as a BIPOC individual, in Wisconsin, just generally, there's a lot of white folks. So when I go to a restaurant or I go out with my friends, the first thing I do when I walk into every room is scan the room to see if there's another BIPOC person in the room. And this is something that I've heard from many of my colleagues, so you can see how awkward it can be for me when I go into an IEP meeting. And it's all white folks in the team, and it's just maybe me and my Latina family in the room. There's that power dynamic. And even though I've come a long way in trusting my expertise, there's still times and there's still implicit beliefs that I'm not as competent as the other white folks in the room. And then there's also just being mindful of how much room you're taking up, how much space you're taking, and how much space you're creating. So giving everyone in the group an opportunity to speak. I've seen a lot of times the caregivers get left out of the conversation a lot. So the team's talking to each other, but no one's asking or checking in with the family, the kiddo if they're there, the caregiver if they're there. So making space and giving opportunities for them to also communicate. And then we have collectivistic versus individualistic cultures. These are all on the handouts that I give you. I'm not going to go through all of it, but collectivistic cultures is more of a we mindset rather than an I mindset, and that's for individuals, right? So collectivistic cultures, you see that most commonly in Asia, Africa, Latin America. Again, things change all the time as more and more generations come up, but we still see that trend. So sometimes we'll tell people like, oh, just, you know, you don't deserve the treatment that you're getting from your mother. You know, maybe you should consider some distance. I'll tell you as a Mexican, that's not going to work. That boundary does not exist. It's very tough to just cut people out because it's about the community. It's about the group. It's not about me and my needs. So you're putting the needs of the group and the community first. So that's important to note when you're talking about setting boundaries, of starting with small boundaries that they set for themselves and not for other people. Let's see. This idea as children and teens get older. In collectivistic culture, it's very common for children to live with their caregivers for several years after they're 18. I've heard a lot of the, my dad said, why are you going to pay for rent if you can live here for free? I'm like, well, it's not really free because I'm doing all the chores and, and taking care of my younger siblings. But it's also hard when you're working with a teenager, let's say, and they're talking about going to college. But it's not entirely their decision, right? Like, oh, my mom's really sick and my dad works all these jobs. I have to stay home. I can't go to college. Whereas, again, more individualistic cultures, that's not to say, it's probably sounding like I'm saying that people in individualistic cultures in North America, Western Europe, and Australia don't care about their family. That's not what I'm saying. I'm saying that a lot of the decisions that individuals make are different. It's a lot easier for folks from these areas over here to set those boundaries without considering anyone else. Family is to be forgiven and defended. This happens a lot with people in domestic violence situations. You'll even hear from the person who's experiencing the abuse from their parents. You just have to change what you do. You have to watch how you talk to them. Your temper is horrible. You have to forgive them. You know, you can't get a divorce. A lot of that comes from, the culture and, area that they're in, but also religion. Those are all things to consider when you're working with these families who are from different cultures, particularly BIPOC individuals. So cultural competency, what can we do? Cultural humility is acknowledging the limits to someone's knowledge of a culture. So you can be a very culturally competent person. You do all of the research, you go to trainings, you have a lot of experience working with a diverse population, and you're still going to mess up. You're still going to make a comment that might not land well with someone. You're still going to have those implicit biases. So it's about being humble. So at intakes, usually I'll lead with, you know what? I speak Spanish, and you speak Spanish. We're both Mexican, but I don't know the specifics to your area. I'm not an immigrant. I was born in the US, so my experience isn't the same as for someone who immigrated here. I grew up with both parents. Not the same for someone who maybe was raised by their grandparents or in single-family homes. So self-disclosure in sessions is quite important for some cultures because they need to know who you are as a human to build that trust with you. So you learn a lot in school, whether it's psychology, counseling, social work, of, just don't share anything about yourself. Well, you don't want to share in an effort to meet a need of your own, right? So you want to ask yourself, why am I sharing this with the client? So usually what I tell my clients at the intake is, if you have any questions about me to strengthen our relationship, go ahead and ask them, and I'll let you know whether or not I can answer them. And that's how a lot of the relationships work. You see this too with openness to medication. So, living in in the U.S., that talk about medication is everywhere. And, we do know the benefits of taking medications in certain cases. However, that's a source of a lot of trauma and suspicion, as I explained in an earlier slide. So, just getting to know the history of medications within those cultures is important. And this whole time, you want to educate yourself. Do not use your clients as a book. If they willingly share something, of course, take it, use it. But, it's not on the BIPOC folks to teach you how to be culturally competent. And then, again, active ongoing self-education, cultural competency trainings. We've all been to really bad ones. But there are some good ones out there. So, just kind of, if you can communicate with the people that set that up, or if you're the person who sets up those trainings, really doing your research. Who's running them? What have people said about that training? Usually when you talk amongst yourselves, you'll talk about trainings that you went to, and you can just flat out ask even today or tomorrow when you're hanging out with each other, have you been to any good cultural competency trainings? Not the most fun topic of discussion when you're in the hot tub, but it's still important to talk about, and this is a good setting. Adequate time to build rapport. This is hard with insurance companies, right? Because they tell me, all right, 3 sessions, go ahead, get rid of the PTSD. I'm like, no, I can't do that. I'd make a lot more money. So if you have the ability to set aside time to build rapport, do that. And it seems a lot of times people feel like they're wasting time by just playing, or I hear that, just playing, or just talking about interests, but you're not. You're building that relationship because you want to make sure that your families trust you and that you show a genuine interest. This isn't just I'm here, I hate my job, I don't really want to be here, because they can sense that. And that's where you see that there won't be a lot of progress, or you might have a large turnover rate. And again, I see this a lot in places that are mostly run from that take certain panels of insurance. Collaborating with religious and spiritual supports. That is totally appropriate and actually recommended. So for people who hold their spiritual beliefs really close to them, it's important to get to know that and learn about it. So an example, again, you'll see a lot of the Mexico ones because I primarily work with Mexican families, and also I'm Mexican. But curanderos, there's actually one right here. It's based out of Aztec culture. They're healers. They do things called limpias or cleansings of someone using different herbs and different plants. And a lot of my clients really find a lot of benefit from going to these folks. And you know what? I never cancel anything out and say, that's not true, there's no science behind it. Because we see things that aren't explained by science all the time. So who are we to say that that's not true? It's not about you believing it, it's about respecting that someone else believes in something else. That's not to accept when there's racism or tolerance of violence within those things. That might be an opportunity to have someone work with a little bit more of a cultural match, because we also want to take care of ourselves. So this is a topic of differing opinions, I guess. So if you're a BIPOC clinician working with someone who is very openly racist, should you continue working with that family? Is it your duty to continue working with that family? Different organizations, employers have different ideas about it. In my opinion, if I'm in that room and I'm not able to feel like the expert that I am, I'm not able to communicate what I need to communicate because of fear or feeling discomfort, that's a time where I would refer out. And you can talk to the individuals about it if you feel safe to. Otherwise, just talk with your supervisors about how that would be addressed. Religious leaders, so, meeting with people's pastors or priests or whoever leads their places of worship. That's okay. You can do that if that's if that individual is someone who your client has worked with together for a long time, they really trust. It's a form of building trust to collaborate with that other person. So if you have the ability to, I do recommend it, even if it's just for one meeting, just to get some more information. Same goes with shamans. So that can get a little bit more into the use of medications or just healing in general. You want to make sure that you communicate with shamans for indigenous folks, a lot of people who practice Buddhism, to understand what your capacity you have in your treatment. How much can you do? What is off limits? Just so that you know. And again, that's where you would make a judgment call of whether or not you are able to, if it's within your scope, basically. Providing a cultural or language match with the providers as much as possible. Again, having someone who looks like you, sounds like you, is important to a lot of people for feelings of safety. So when possible, providing that match. And again, not every provider is for every family, so even when you have those matches, it might not be a good fit. So that's where, as white folks going into homes, that's where you want to really focus on the cultural competency training. If you speak a different language that matches the family that you're working with, making sure that you're staying up to date with the language, because they probably don't teach psych and social work talk when you're learning Spanish in college, right? That's a very specific area. So even for myself, I still need to learn all the words in Spanish because I didn't talk about, PTSD or EMDR with my parents. And providing materials in the client's language and using interpreters. Again, ideally you would have a language match, but when not, providing that interpreter. This is very, very important. I have worked at places where they don't have consent forms in Spanish, but they require signatures on the consent forms to get treatment. So my clients have to have everything signed before the intake, before I have an opportunity to talk about what those informed consent forms say. Not ethical, but it happens all the time, right? So a lot of folks that aren't English speakers who have their materials in English are just signing things because they were told to sign them. So really advocating for that if your organizations don't do that now. So in review, you as DuraCare providers become attachment figures to your clients, to the kids you work with, the adults you work with. And that's a big role to play because sometimes you might be the first person who sets a boundary with these folks. You might be the first person who's shown genuine concern or has pointed out that shouldn't have happened to you. And trauma is not about what happens to you, it's about how your brain processes it. So you can't tell someone that's not a trauma because it doesn't fit the big T traumas. If someone finds it traumatizing, that's how it was processed for them. There's more research coming out actually about bullying, right? So if you think about chronic stress and trauma, cortisol levels are always high. You're always looking for a threat, always hypervigilant of your surroundings. All symptoms of trauma. And it happens every day. And it's unpredictable. You don't know if you're going to get beaten up or have someone say super mean things. So teaching that psycho-ed too to the caregivers is important, right? So bullying should not go unaddressed. A lot of times, caregivers have heard worse and have had worse. That's valid. And at the same time, it doesn't change how the child might be processing it in their brain. There's different protective factors for everyone. So it's important to be consistent, honest, and transparent. Giving adequate time if you know you're going to be out of the office. Making sure that that is pre-planned vacations and things, just giving as much notice as you can, right? So that they can prepare, because if you're the attachment figure for them that's secure and you're gone, there's a lot of anxiety and fear that comes with that of, I'm not going to be able to handle it, I'm not going to be okay. So then you can spend some time before that absence preparing them, kind of working through like, okay, I'm not going to be here, but I have people covering for me. Do you want me to show you their profile or their bio? Or making plans, making sure safety plans are in place for people who are in violent situations or have any sort of suicidal or homicidal thoughts or ideations. Again, collaboration is important. So a lot of times we get the sense that people are telling us like, fix them, fix me. So if you're working with families, sometimes you are viewed as the authority figures. And you know what? Yeah, you're experts at what you do, but those caregivers and children, they're experts of their own lives and their own experiences. So don't let, the trainings and the schooling and things get you to a place where you're not able to meet someone where they are. Because you know a lot, and I want you to be confident about it. and at the same time, really get to know someone before you tell them what to do about something that's happening. Appropriate play in psychoed. Again, I use a lot of art for my psychoed. I'm not an artist at all. But in my simple stick figures or bean-shaped brain images, my kids, they know it. They're like, yep, makes sense, cool, thanks. And then every time I will have the child try to explain it to the parent, if it's a secure relationship or relatively secure, because then you work on the attachment, but then also you can see if the child retained the information. It shouldn't be a test though, so help them out if they're struggling, but give them the opportunity. Use judgment and expertise. So I've heard from a lot, I've never been a teacher or in a teaching position, but with a lot of my teachers, there's a very strict curriculum. And in a lot of places, you're expected to get to this at this time, and everyone needs to be there at the same time, right? We're not taking into account all these kids are different, and they have different experiences and abilities to learn. So you can still get through the curriculum while you enhance the materials for certain children. So we hear a lot of like, you need to sit down and stay in your seat with kiddos that are have sensory sensitivities or ADHD or autism, right? Like that's a way of soothing. And if you think of bilateral stimulation, how many of you, when you're on your phone, pace around? I walk in circles around my bedroom when I'm on the phone, right? So it's a way of regulating, and those kiddos that need that movement or need to be standing are going to learn more rather than forcing them to sit in their seat. Spending time, again, on building rapport. Can't emphasize that enough. There really isn't a specific number of sessions or meetings to build that rapport. It really depends on the family. But you'll get a sense of it, right? Like if a child is sharing more about their week, right? Like with my teens, I get a lot of the, it's fine. Did anything happen this week? No. How are your friends? Good. So I'll usually be like, yeah, I feel like I was there. Why don't you tell me why it was good and not bad? So open-ended questions with the kiddos and the teens are clients that tend to not just openly speak about things. Rapport, going back to age-appropriate stuff. You can't expect a child to just talk to you for a whole session or a whole meeting. That's not fun, first off, but also their brain isn't at that level yet where they can process through their emotions and regulate themselves. That's all prep work, and that can all happen while you're building rapport, through play, through mindfulness, through all of these things. So spending time there is more important than trying to teach something when someone is already activated, they're locked in their downstairs brain, they're not absorbing that information anymore. And taking care of yourself, right? Going back to mirror neurons. Yeah, your clients can tell when you're having a bad day. You might be offended if they're like, oh, you look tired. But you do. And they can tell something's off or that your sleep is off. So taking care of yourself is important. Self-care, getting your own mental health supports. I really believe that if you're a therapist, I don't know if there's therapists in here, you should have your own therapist. If you're going to teach a skill or recommend a book, you should have read it yourself and implemented the skill yourself. And mental health supports can be a therapist, psychiatrist, life coach. I have feelings about them, but that's okay. You know what? They help a lot of people too. But they get a lot more money without a license from me. So it can be just support people as well in your life, spending time with those who are important to you, doing leisure activities, find a hobby, anything. Anything. I took up cross-stitching, I thought, a few weeks ago. Haven't touched it. But I tried. I got a paint by number. Haven't touched it. Still in the box. But I got an app on my phone that's color by number, and that I've been using all the time. Micro, meso, macro breaks. Micro breaks are breaks you take throughout the day, just short ones. You take 5 minutes to make sure you're hydrating, make sure you're eating, have a snack. Sometimes you have to do it as you're writing notes. I know paperwork is tedious. Meso breaks is 1 to 2 hours each day to do something. Not during the workday, it doesn't have to be, but to do something that you enjoy for leisure. And then your macro breaks are taking at least 1 day off work a month. And again, I realize that that's not possible for some folks. Unfortunately, in the mental health field and social work and human services, they've got a long way to go on how to retain their people and have them take care of themselves. Burnout is huge. So we do what we can. And then boundaries. Setting boundaries if you can. If you're not a crisis worker, if you're not required to be on call, have strict hours. I'm a host for karaoke on my free time. I pulled up my work email while someone was up there singing, I don't know, some song that I wasn't really listening to. Shouldn't be doing that because then when I see an email from my boss, panic. So make sure that you're working during your work hours and try to not check your emails if you can. Also have that listed in your signature, email signature, or whatever messaging system. Have an automatic message that says, I respond to all messages that are not crisis during these hours. And then people will slowly start to be like, well, I'll send it anyway. They can check it later. Or, okay, I can wait. And vacation time. If you have the ability to take some time off, you deserve it. If you have the ability, you deserve to have true days off, not just when you're sick. So in conclusion, we're trying to move towards secure attachment. We're trying to meet our families where they're at, want to incorporate these attachment-focused activities, and practice cultural humility. And again, everything's different for every person, but I hope this was at least helpful for some of you to approach with your families. Thank you. I don't know if I might have gone over. How much time do I have? Are we out? Okay. So there's my information. Please email me that info. I'm also on that lovely Hoover app. You can send me messages there. So I hope this was helpful. Reach out to me if you have questions. Sorry, I forgot. I wasn't looking at Rose. I'm sorry. I saw you do this, and I'm like, there's 2 slides left.